Hi guys, welcome to my YouTube channel. So today we'll be discussing adenoiditis, which is a very important topic in your ENT subject, and it has a very high chance of coming in your exams. And I've covered this topic in very basic headings. So if you write in that way only, you will get a very awesome marks. So I've covered it very crisply, and the PPT is also available in my Telegram channel, and the link will be given in the description box below. And I will also give you a tip to solve these questions at the end of the video. I will give you a very small hint. So I hope you watch this video till the end, and I hope you like this video. So without further ado, let us get into this topic. So if you can see this picture, this is the oropharyngeal area and this is the nasopharyngeal area, and the adenoid is present in the nasopharyngeal area. So where are the tonsils, the palatine tonsils and the other tonsils present? These are present in the oropharyngeal area. So if there will be adenoid hypertrophy, that is the adenoid will be swelled up here, so the patient will complain that he's not able to breathe through the nose, so we'll open his mouth to breathe. So this is the main chief complaint of the patient with the adenoid hypertrophy, that he's having nasal obstruction and difficulty in breathing, so his mouth will be open. So first let us look at the anatomy of adenoids, that what is adenoids, what's its blood supply, nerve supply and lymphatics. So adenoids is a nasopharyngeal tonsil and it is situated at the junction of roof and the posterior wall of the nasopharynx. If you can see in this image, the adenoid is present in the between the roof and the posterior wall of the nasopharynx. It has vertical ridges, it has no crypts and no capsule. This is a very important point. Why? Because as you have learned in palatine tonsils, it has crypts and it has a capsule. This is the main differentiating feature between the adenoids and the palatine tonsil. Its lining epithelium is ciliated pseudostratified columnar, stratified squamous and transitional. So these adenoids are present at birth. At birth only they are present. They enlarge up to 6 years. They atrophy at puberty and they completely disappear by 20 years. This is an important point, that adenoids are basically a normal thing which was present at birth. It enlarges up to 6 years whenever there's an infections or any upper respiratory tract infections, or any, if the child is suffering from sinusitis or rhinitis, these enlarge and they atrophy at puberty and they are disappeared by 20 years. So what is the blood supply of adenoids? It is supplied by facial artery, the branch is ascending palatine, external carotid artery with ascending pharyngeal branch, maxillary artery, pharyngeal branch, and the inferior thyroid artery, ascending cervical branch. So it is basically supplied by the facial, external carotid artery, maxillary and inferior thyroid artery. It drains into the upper jugular nodes and is supplied by 9th and 10th nerve. These are also the nerves which supply the ear. So therefore the patient has also referred pain in the ear because the supply is the same. So this was the basic anatomy of the adenoids. So now let us see what happens in adenoiditis. Basically adenoiditis, itis means inflammation. So there will be hypertrophy, there will be swelling of the adenoids. And why is this happening? Because of recurrent attacks of rhinitis, sinusitis and chronic tonsillitis. These can lead to adenoid hyperplasia also. There can be generalized lymphoid hyperplasia and any allergy of upper respiratory tract. So all these things can lead to adenoid hypertrophy. So as you can see in this photo, this is the normal adenoid which is present in the nasopharyngeal area. There's also eustachian tube opening in the nasopharyngeal area. So whenever there is adenoid hypertrophy, firstly it blocks the breathing passage, so the patient will breathe through the mouth, and also it blocks the eustachian tube opening. So therefore there can also be middle ear infections. Now we'll see the clinical features, that is the nasal, the oral and the general clinical features. So you can when you are writing in your exams, you should write the clinical features in this manner only. There are some general clinical features which will occur in all the patients. there are nasal clinical features, and there are oral. Oral means ear. So nasal obstruction is the most common clinical feature the patient will present to you. He will say that he is not able to breathe through the nose and he can only breathe through the mouth. So he will come, or he or she will come with an open mouth. And there is interference of feeding or suckling. That is when adenoiditis happens in a very small baby, and while you are feeding him or her, he will deviate from while feeding, because he has to breathe also through the mouth. He has to eat also, he has to breathe also. So while feeding, he will deviate. So this will lead to improper feeding, and improper or interference of feeding, which will lead to failure to thrive. So this is a very important point. This is a very important point, that the child will present with failure to thrive. There can also be nasal discharge, wet bubbly nose of the child, sinusitis. The maxillary sinusitis is most common. That is, the patient can present with nasal obstruction, with adenoiditis, with sinusitis also. Epistaxis, and there can be voice change with less tone and loses its nasal quality. So these are the nasal clinical features. So now let us look at the oral clinical features. There will be tubal obstruction, as we have seen in this photo, that the eustachian tube opening was blocked when there was adenoid hypertrophy. So this tubal obstruction will lead to retracted tympanic membrane, which will lead to conductive hearing loss. There can also be recurrent attacks of acute otitis media, chronic suppurative otitis media, and serious otitis media, which presents with fluctuating hearing loss. So these are all the features which can happen due to the eustachian tube blockage, and these are all the oral clinical features. Now let us look at the general clinical features. In this, a very important viva question comes, or this PBQ, the problem based questions. These all the symptoms will be written in the PBQ. So what is adenoid facies? A very important viva question. There will be elongated face, there will be dull expression, there will be open mouth, prominent and crowded upper teeth, hitched up upper lip, nose pinched in, and a high arched palate. These all features will be seen in the patient, like in this photo also. You can see the high arched palate, the open mouth, the dull face, the elongated face, or the crowded upper teeth, nose pinched in. All these are features which are combinedly known as the adenoid facies. And the other clinical features are pulmonary hypertension or cor pulmonale and aprosexia. This can also come in your PBQ. So this is also an important point, that aprosexia means lack of concentration. So the PBQ or the clinical question can come as that there was a child with who is suffering from lack of concentration. He's not able to study well, and he has a very dull expression on the face. He has an open mouth. So these all things signifies or directs you towards adenoiditis. So how will you diagnose this when the patient comes to you? You'll have a rigid or the flexible nasopharyngoscope, or you can also use the laryngoscopic mirror to see this adenoid hypertrophy. You can also order an skygram or the lateral x-ray, the lateral view, and you can see the size and the extent of adenoid. So here you can see the adenoid blockage in the nasopharyngeal area, and detailed nasal examination. So these are the points you have to write in the diagnosis. This is how the adenoid will be seen in the laryngoscopic view. So what will be the treatment? Now this is important, and this is something you have to study in another video. I will share the adenoidectomy video also. So what is the treatment that you have to tell the patient? Breathing exercises, decongestant nasal drops, antihistaminics, and adenoidectomy if you have to remove the adenoids. So these are all the things which will relieve the rhinitis, sinusitis, and the nasal symptoms. And adenoidectomy is basically the removal of the adenoids. So in this we use St. Clair Thompson adenoid curette with guard. So there is with guard and without guard also. So this is the instrument we use. It is held like in a dagger like position, that is like you are holding like a dagger, and You stand at the this side of the patient, at the back of the patient, and then you remove it in this manner. So this can only be learned through a video, so we'll discuss this in another video. So basically this was all about the adenoiditis, the anatomy, that what is adenoids, the etiology of adenoiditis, that is the attacks of rhinitis, sinusitis, tonsillitis, lymphoid hyperplasia, and allergy of the upper respiratory tract, the clinical features which can present as nasal, oral, and general, in which we learned about the adenoid facies, aproxia, the failure to thrive point, which are very important. We learned the diagnosis and the treatment. So this is all about adenoiditis. The tip I was about to give you is that in how can you solve a PBQ of adenoiditis. So firstly, if there's a hint, like if the age group is below 7 years, then you have to direct towards adenoiditis. It's a very good point that the patient age will be given less than 7 years. And also the star marks point, the aproxia, the adenoid facies, the failure to thrive, these are some points which direct you towards the adenoiditis PBQ. So look for these clues to solve your PBQ. And that's all for this video. Thank you so much for watching. I hope you like it, and please go to the description box to join my Telegram channel, and all the notes will be given there. Thank you and have a nice day.